Hey everybody, Dr. Rob Silverman here. I'm with esteemed colleague, Dr. Ken Johnson of Johns Hopkins University. You know, I've always wanted to ask somebody, why is it Johns and why is it Hopkins? Were there two of them?
There were not two. It's actually one man. Uh, Johns Hopkins was actually the amalgam of two last names. So he took his father's last name, surname, and his
No.
mother's surname as his first name. So Johns Hopkins is one man.
Mm. Well, it's
He
good.
he bequeathed his fortune that he amassed around at the time in the late 1800s. It was around $11 million, which in
Okay.
today's world would be about 7 or 8 billion in
Wow.
finance. Yeah,
Wow. Well, an esteemed, famed university. I want to dig in right away. I want to talk about the model for pain management, rehab, and recovery. You're an expert. So tell me all about the pain management model for recovery.
sure. Really, life and experience is sort of shapes our practice, and in learning things that worked and didn't work. When I went to PT school a number of years ago, we had this class in physical agents, and we learned about all these devices and things that were going to help change and manipulate the physiology of healing in our patients and help them recover faster.
Right.
What I quickly learned as I exited uh, my schooling and into practice was that we were heading into the functional age. Everything was moving away from dynamometry and modalities, and it was all about manual therapy, functional
Right.
training. The greats that helped um, propel us into a profession that is focused largely on movement recovery.
Yep.
Um, Modalities started to fall by the wayside, and you know, I think that there was always an interest in them
Mm.
because you know I look at uh, I look at other trades. The craftsmen of today, nobody builds a house with a hammer and nails,
Right.
or a handsaw. There's power tools, and so always trying to look at ways to be efficient and effective, meet our patients' needs and expectations, but also differentiate the way in which we get them to that healing point. Um, Always in the back of my mind was interested in how technology can accelerate the recovery process. And whether it's again dynamometry and data-driven decision making that comes out of taking measurements, whether it's strength, force, range of motion, gait analytics. All of those things have always been very interesting to me. So I deal a lot with runners and athletes with an eye towards, returning to a sport or an active profession. And more than anything, I like getting the patient who has been to multiple providers and has been told at some point along the way, yeah, you can't do it or you shouldn't do it. And at Johns Hopkins, we find a lot of people that they've tried other solutions and then they look to Hopkins as a, you know, institutional leader in both research and medicine, and they come to us looking for hope or a solution. And so being sort of at the end of that proverbial line, um, I think it's important that we equip ourselves with evidence and science, but at the same point, keep our options open to explore new things or things that haven't been done or tried before. So I've got to be that guy. It's having a creative solution to help them solve the problem. So for me, long answer to a simple question, is this multimodal approach to managing soft tissue injury and recovery
Mhm.
um, is really the product of 30 years of clinical practice, um, time spent working on the industry, and then integrating those clinical and industry experiences back into a model that is physiologically based, to help someone progress through a healing stage.
So I really love what you said. If I can decipher it all and just translate a little for you. Number one, less modalities, maybe devices, but not modalities. Everything's based on function. Makes total sense. I mean, that's one of the first things that we look at. Is it a functional injury or is it a structural injury? Interestingly enough, at Johns Hopkins, you're really getting the tough cases, which I love to hear. I'm having some issues in my gums, and a lot of the practitioners, they're very well schooled, but they don't want the tough case. I commend you. I'm compelled by you that you want to take on the tough case, because you know what? Those people think there's no end in sight. And I agree with you. I think, you stated you had 30 years of clinical practice. You certainly don't look your age, but having 25 years of clinical practice means something. Experience means something. The thirst for knowledge means something, and based on function, I think that's great. So I'm going to get you down a little bit. I see that I've got this slide that you sent me that we want to go over about a multimodal biophysical model for pain management, rehab, and recovery. So why don't you go through and tell me, I see that you use topical anesthesics, use mechanical therapy, things like that. Why don't you give me some of your tenets of what you do when a patient comes in?
Yeah, so I look at things from sort of the standard healing model. I mean, the phases of healing: homeostasis, inflammation, proliferation, and remodeling. So going back to that difficult or tough patient who has taken, and in many cases been down either the manual therapy or the functional training approach. And it's sort of like they it's like the cake that got baked. They have all the icing, but the cake hasn't been baked yet. And that is where we can use modalities to help set the stage to sort of work on a physiological reset at a cellular level in order to be able to then build a, a, a scaffold of healing around that. So in looking at how we progress through that and the acuity of symptoms, and phasing the modalities in such a way that we we hopefully get the most out of them, is essentially looking at, where do I begin? And where I like to begin is with tecar therapy. Tecar therapy stands for the transfer of electrical current through capacitive and resistive means. And tecar, that acronym, sounds a lot better when the Italians say it, as it was invented in Italy, is a way in which we can begin to help restore, the cellular metabolism, fluid exchange within the cellular complex, and then also work on restoring the oscillation frequencies of the cell itself, and restoring that to sort of its optimal state. It's a gentle treatment. It's warm. It feels good, but it's deep. Much like the old, again, back to my school days, diathermy. Diathermy penetrated deep. It was a unique kind of feeling. It was different than a hot pack, but it had some other issues that, we don't use it as frequently in practice today. Tecar therapy is a radio frequency current. It's a high frequency, so it is not it is not motor. It's more sensory and thermal in nature. So increasing cellular metabolism, reducing pain, and providing some heat. Because what I'm going to follow with are treatments such as mechanotherapy, photobiostimulation, muscle activation through pulsed electrical magnetic fields. And ultimately, at the end of that spectrum, the hierarchy is working on movement. So I'm not throwing out
Right.
the 30 years before, but trying to integrate in what's available to us today from a technology standpoint and incorporate it in with the movement-based sound exercise principles that we've always known and believed in.
So we had a discussion before. Ken's a PT and I'm a chiropractor. So we're both at different sides of the coin, but together we make the full coin. And we both agree that we look at the whole coin, if you will, if I could use that as an analogy. So I'm not a heat guy. I'm more of a cold guy, but I agree with you about what you're talking about. The cell has to heal and cellular rejuvenation and cellular recovery. I agree with you on the frequency of the oscillations of the devices, whether it be laser or shockwave, etc. In addition, I mean, I think that what the idea, the Goldilocks effect, has really taken over now. So a little heat, a little cold is really where we're at right now in manual therapy, because we're talking about things that are outside. When I say outside, there are alternatives to the medical model, which would be drugs, nothing wrong with it, injections, and surgical intervention. We're trying to avoid that as best we can and restore function to the cells. And function is really based on, I think you said it, on movement. And I'm going to hit you with one. Are you ready?
Okay, here we go.
A tendon never goes back to its original histological length without appropriate treatment. Ponder that.
Yeah, I mean, that's a good one. I think, there's a lot of things, I guess my approach to that is more that I don't know that, I'm ever going to change the length of a tendon. But I think I am going to change the inflammatory effect that occurs at the musculotendinous or tenoperiosteal junction. And I think, that's why some of the things treatment-wise, modality-wise, that I really like, focus shockwave, shockwave and radial shockwave too, up at the musculotendinous junction. But, focus shockwave at that tenoperiosteal junction is an exquisite experience for a patient. I can't get there with my hands. And I think that is one of those catalysts that's been very effective in helping to jumpstart the recovery process. As we teach and train tissue resilience, it's been a sort of a signature of mine in some of these most challenging cases. And my client coming in at noon today is a product of that. One of the fastest men in the world, Achilles tendinopathy, told by multiple people he needed surgery. Surgery could affect his ability to run. Did he so choose to do that? No, he chose a multimodal management strategy, one where we were working on all of the tried and true things that we should do, but we added in this additional layer to begin this reset process within the tissue. So,
I'm going to interject because a lot of the followers may not know Achilles. You said Achilles tendinopathy. So the Achilles tendon is a part of the body that gets the smallest amount of blood flow. It takes a long time to heal, everybody. It is one of the interesting anatomical portions of your body. It's a tendon inside another tendon, not a sheath, but it's actually inside what they call a paratendon. So that also makes it a little bit more challenging. So what Ken's talking about, giving somebody a response, the average practitioner is going to struggle with that. That said, I'd love you to define the difference between shockwave and radial shockwave.
Fantastic. So there's two types of shockwave. We have radial shockwave and focused shockwave. So a radial shockwave is one where there is a very high intensity force or energy that is imparted to the tissue that is at the most superficial layers.
Good explanation.
A high shockwave, and then we hope to dissipate that energy down into the target tissue. Very effective. Lots of evidence and research that shows its benefit on tissue and tissue healing, but not super pleasant to be treated with. And that it's kind of my journey into Shockwave was as a patient myself. I went to a friend out in LA um, for a visit, and I was having some knee pain. He treated me with the radial Shockwave. It honestly, it was like having a dental procedure without any Novocaine. It
Mm,
was unpleasant, but amazingly effective. And like the
beautiful.
lights came on, and I started, investigating these different types of treatment. I learned about focused shockwave, which is where, in that case, we take a lot of little shocks and we converge and focus them down deep into the tissue. Um, the best way I can describe this is like if you've ever been snapped with a wet towel. If
Oof.
you just get hit with the towel, it's no big deal.
I think they call
You
that a
get
rat tail.
snapped with that towel, all of that energy is focused into that impulse, and that rapid impulse and deflection um, is the shock that is not an electrical one, but an acoustic shock. And that shock has a profound effect on the pressure sensors in and around that sense, uh, you know, change in the environment around the cell. When we have those rapid changes in pressure, in mechanical stress, what we call mechanotransduction. When mechanotransduction takes place, it's a mechanical force, but it is um, met with a chemical response. So our body then begins a cycle of repair and regeneration. Much like if you go skiing, haven't skied in a while, your muscles are really sore the next day. Um, if you by the end of the week, the muscles aren't sore. You can be skiing more and more. The muscles don't increase in their soreness because your body changes and adapts its ability to tolerate that stress and become more resilient. The same is true at a very specific tissue level. Shockwave just allows us to target that force in a very safe, effective way to elicit a very specific healing response.
Now, you use shockwave, radio shockwave regularly in your practice, correct?
Yes, I would say that in percentages, I would say that I use a focused shockwave probably 90% of the time. We reserve, there are some cases where I have a large trigger point or a trigger point over soft tissue muscle mass that I do kind of like the radial shockwave, for that, particularly like upper traps where you see a lot of,
Yeah.
tension headaches and things like that. I think the radial works very well there.
Now, I
So
know
that,
you also, and both of us use laser therapy. So there's a full spectrum of a conversation in laser therapy. So I want to set you up to let you start the conversation. Everybody knows that I like low-level laser. My preference is photochemical, most photothermal, but I know you on one side of the fence and you're kind of coming across the line, if you will, as you indicated before we came on. So just let me know where you are, what you like, and what the followers can adapt to.
yeah, sure. I think John Wooden said it best, the famed basketball coach, when he said, "It's what you learn after you know it all that counts." And, I, like a lot of other people, have been following the laser sort of escalation, right? When medical lasers first came out and started coming into the hands of the therapist, they were, in the milliwatts, very low powered laser. And, kind of that mindset, like more is better. So, as technology kept advancing, as the quality of the diodes kept getting better and better, as manufacturing and science, everybody kept pushing this curve, up and up. And I mean, there's some lasers out there that are well over 100 watts. I mean,
Mm,
crazy powerful lasers,
crazy.
crazy expensive lasers. And so, in your own practice, you have to make decisions about like what you can afford and what makes sense. And it started to sort of hit this point where, things are sort of so far out of reach in some cases that, that's just kind of out of my realm. But as we got there, it's not that I necessarily saw remarkably different outcomes or benefits from the more and more power. I think you get to this thermal or sensory disturbance this hyper irradiation a lot faster because I can blast you with 40 watts now.
Right.
I can also, really elevate your tissue temperature pretty significantly and to a point where that's probably not the best thing to do. So I've actually taken a detour and a few steps back is a few years ago was introduced to a super pulse laser.
Mm.
Why would I buy this super pulse laser that's 3.3 watts, averaged um, over time when I got a 25 watt or I got a 40 watt. Um,
Right.
and what we found was that, you know, while no, patients didn't have some of the same sensory and thermal effect, it got remarkably better. And we would see changes in session of strength output. And it's like, well, how is that
Right.
possible? Because we know that we don't get stronger in 30 minutes. Um, so there was something to it, and that sort of led a little bit of a detour back in looking at maybe I'm missing something here. And there's a lot of really interesting lasers out there that are class one, two, three that are at a variety of no pun intended of the spectrum
Mm.
um, that honestly, they meet the needs of the patient or the therapist if you're open and willing to look for these creative solutions.
I love your answer. And you and I in agreement. I utilize low-level laser daily on virtually all my patients. It is within my chiropractic toolbox. So for me, low-level laser is photochemical, not photothermal. I
Yeah.
actually like the power in the milliwatts, not even watts. I love the low level power because I found no heating to any tissue, therefore no deleterious effect. And
Mhm.
like you said, the spectrum, we're talking about the visible light spectrum. So I like to use an array of different wavelengths and colors. 635 red has some very unique health benefits, such as mitochondrial resuscitation for what we call complex 4. I like the green light or the green wavelength, which is a 520 to a 530 wavelength, which produces stem cells very efficiently, also has an immune enhancing effect. And lastly, the third one, and maybe the most interesting one on the spectrum, would be a 405 blue violet light, which is great for immune health and also fabulous for a lot of bacterial and viral infections. So when you get all three, you get this whole synergy going on. And in addition to that, they allow the stimulation of mitochondria complexes 1, 2, 3, and 4, which you indicated you noticed when you utilized the laser that they got stronger. So for me, laser without question is a choice for every manual practitioner in the US today.
I completely agree. And I think it's very interesting. There's a paper published by a good friend, Phil Page,
Right.
and colleagues a couple years ago, where they surveyed nearly 2,000 physical therapists, and they asked them about practice patterns and adherence to, the evidence. Is that's one thing that we hear oftentimes, like, well, is this evidence based? You know,
Right.
in 8 of 11 musculoskeletal conditions, over half of the responding therapists in that survey did not adhere to or follow the evidence. Because there is some, we know with neck pain, with a number of different musculoskeletal conditions, laser is an outstanding choice for modality. And in some of those cases, less than 6% of the responding therapists acknowledged using laser. But instead, they would use a surface electric stim or some other treatment that may have some anecdotal, but did not have the rigors of science behind it and its application.
I
So
am
yeah,
so happy you said that we are evidence-based because that is one of the knocks against the alternative practitioners. And laser, shockwave, core activation, which I want to segue into, all the things that we do are based on the newest evidence. So now that I said core activation, you and I are both involved utilizing a device. I'll call it device. You may want to correct me on that. It's called Backbone. I'm good friends with Dan Crater. I think you're his science officer. I'd like to talk about it because when he first sent it to me, I've got a postural fault. Man, oh man, oh man. That reset was hard and I'm still working on it. So I'd love you to take the baton and run with it from there.
Yeah, I think, the backbone is an interesting device. I mean, I think again, I look back into practice and it's honestly it's one of those things where, you think, God, that was such a simple idea when I think of that. Since the dawn of my practice, incorporating posture and some forms of either neutrality of the posture into our lower extremity exercise progressions. Yeah, I know that if I don't have a good core activation, it's going to change my lumbopelvic alignment, and then that can mess things up both above and below the kinetic chain. So, we've all used, most of us, if anybody's treating a spine, has used a dowel or some sort of stick or some sort of something that you hold on to try to teach someone that 3 points of control. And when you do that, you tie up both hands. So you can't do anything functional, which takes us away from all the functional training we like to do. So the backbone really was just a very simple, low-tech design developed by a back patient, honestly, who his therapist sent him home and said, "Hey, use a stick and do these exercises." And I love stories like that
Mm,
because sort of the genius of it is not um, in the technology, but in the solution to something that hundreds of thousands of um, physical therapists, physios, and chiros around the world have used a stick at some point to train neutral spine. So I think having that awareness is really one of the keys for its success because um, I've used it on patients, even just in a walking program, because they'll be a little kyphotic, um, and again, the head position changes where the rest of the body follows. So if I can get the cervical spine to retract a little bit for them to bring in their deep neck stabilizers and be more posturally neutral, not to the form of being like rigid, but aware. It uses different muscles. Suddenly, we start to see the
yeah.
hips activate in a walk. And again, my client who was told he wasn't going to run or compete internationally at a high level, um, kind of laughed at me a little bit. Like, what, you seriously want me to walk through my neighborhood with this thing strapped on my back? Yeah.
I hear you. And I agree with you with the 3 points. And when your posture improves, it gives you what they refer to as a halo effect. And that halo effect is the idea of that your confidence. It's kind of like looking at someone at center stage and they're standing there, and that halo allows them to project almost an angelic feeling for everybody who's watching them, and it gives more self-confidence. And a lot of that really does start in the core. So what I want to do now is we always go like in the middle when we talk about fun facts, rapid fire. So we're
Okay.
going to speed you up. We're going to get to questions a little quick. We're going to try and get a whole bunch of questions in 60 seconds or less. Here we go with the fun facts. Number one, hot or cold?
I in the middle. I tend to be a little bit more to the warm side than the cold side. But like with everything, it has its place and its time.
So we'll call it the Goldilocks effect. A little of each, just right is best. Number
Correct.
two, core activation. What do you like?
Core activation, I really like a lot of Tim Anderson's work. He's not as well known, strength
Okay.
and conditioning guy, sort of a follower of Gray Cook and sort of the FMS crowd.
Over there. Yep.
But he really, I think, put it into a very simple program: diaphragmatic breathing, head control, rolling, rocking, crawling, and moving that into a functional training paradigm that has a combination of progressions and regressions depending on where the patient's needs are at. When you look at the hard science, I mean, I think of like McGill has done a
Right.
tremendous amount of work in elucidating a lot of the biomechanics of the spine, and like
The king, Stuart McGill, without question. Hope to get him on a podcast. Um, Proprioception.
proprioception. I mean, so I have the privilege of doing some speaking with Kevin Wilk, and Kevin is one of the premier sports
Sure.
PTs in the world. And it's always very interesting as people show up to his 2-day lectures expecting to learn a lot about musculoskeletal orthopedic therapy for the shoulder and knee. And the overwhelming majority of time is taught what he's showcasing is really proprioceptive training. The way in which to get and elicit muscles to respond the way you want them to work in life, on the field, at work, um, is
Outstanding.
to create perturbations and to create challenges and adaptations to stress and anticipated stress. So yeah, proprioception's huge, and there's some really cool new technology that we just got to look at. And I'm super excited about a device called Upright VR. Upright VR has taken and brought the balance center. So devices that used to cost $100,000 now for just a couple thousand, clinicians can have a device that gives us a definitive breakdown between ocular, sensory, peripheral sensory, and vestibular, and then also an organization, and how all of those are organized. Because sometimes somebody can be really good with their eyes, sometimes they can be good with their peripheral adaptations. Inner ear can be okay, but how the brain processes and reorganizes all of those signals can sometimes not always work in unison. So, equipping and arming even musculoskeletal people like me with tools to better assess balance and proprioception, I think we're going to see a lot more of that as the accessibility to this once very specialized testing starts to make its way into the hands of chiropractors and physical therapists around the country.
Excellent. So I see that you put your full body into the water of supplements. So let's hit each supplement one at a time. Allulose, the rare sugar, thumbs up for me.
Yeah, I'd give it a thumbs up. I mean, it's really interesting and intriguing. I mean, it's relatively new on the market, and while I'm not a nutritionist, I understand where my practice boundaries lie. But I think, educating and um, uh, directing our uh, clients to learn and seek out, talk to their doctor about what may be right for them. Allulose is very interesting as it's no net carbs, zero glycemic impact, and in some studies is showing a reduction in blood sugar,
Yes.
and is remarkably tasty. It's not a sugar alcohol, so there is not, some of the risks or side effects that we see with that, some of the other sugar alcohols that are out there. So I think it's a one to watch, for sure. I think it's a one to watch.
I like what you said, one to watch. It's a star on the rise, without question.
Absolutely.
Resveratrol, David Sinclair aside, what's your feeling on resveratrol?
So I think one of the things you touched on earlier, blood flow, everything is, we can actually kind of go way back. And that's where some of my comments regarding, thermals, back in the caveman days, they didn't have hot packs and they didn't have cold packs and things like that. They had rocks that would heat up when the sun would shine and they'd cool down at night. And some of the early thermals, what did cavemen do when they had a backache? I'd love to know.
Mm.
Did they go lay on the rock during the day or did they go find a cool spot, in a cave? I don't know. But it intrigues me to think about the things that we have access to us today. Um, I got way off topic there. But the things that we have access today, the hot, the cold, aqua therapy, um, I look at the things that have been around for a long time. Now, resveratrol, as a vasodilator, blood
Right.
flow, we need blood flow
Yes.
into, again, a healing Achilles, which is very far away from the heart, um, very low in blood flow. What can we do to create um, an increase in the vehicle that brings nutrients for healing in and carries waste products out? So Vinia is interesting, and there's several different products out there. Whether it's a resveratrol, there's sort of the nitric oxides that comes from all the different beet derivatives, and there's aronia berries and things like that. There's a lot of cool stuff on the market, and I don't like endorse one, but I encourage people to um, talk with their doctor, talk with nutritionist. I mean, test and see and read for themselves what may or may not be right for them. But Vinny is an interesting product that's come out in the last year or two as a derivative from grapes and red grapes, and this
Right.
idea that um, we can take and consolidate. I'm not going to eat 1,000 grapes a day, but to get 1,000 grapes or the benefit of eating 1,000 red grapes per day, or drinking 5.5 bottles of wine. I'm not going to drink 5.5 bottles of wine a day. That'd be a problem. Um, there's something to it. So I think it's interesting.
Great explanation of resveratrol, and I agree with you. Nutrient ingestion and toxic egress is critical for overall health of the cell. We want to choose supplements, nutrients that aid us in that goal. And you touched on nitric oxide. It's been the, no pun intended, the explosion now, NO2. NO2 is great for overall, like you said, vasodilation, excellent for heart. A lot of men are using it middle age for ED. And we actually test for NO2 on all my patients every morning or in the morning to see their NO2 levels. And I'll say this, 85% or more of my patient base has NO2 levels that are just diminished, virtually zero. So
Huh.
I think it's the new hot conversation piece, or one of the new hot conversation pieces. Now,
Well, and NO2 is the secret behind that little blue pill too. So I mean, blood flow
right.
it impacts not just our athletic performance, but performance in other ways. And that is, again, when we think about treating our patients as a whole, there's a lot of different aspects of life that we can positively impact by educating them to solutions that are out there.
How about glucosamine and ASU? I see that you put that in the show notes. So
Yeah,
when
so I think again, looking into the science, this is another one that's sort of interesting from a controversy because the American Academy of Orthopedics, had a paper published 10 years ago or so where, they were sort of equivocal about the use of them. And it's been interesting conversations I have with colleagues about, their thoughts and beliefs in it. There has been subsequent studies, randomized controlled trials, 1,500 subjects or more, where they're using, glucosamine, chondroitin, not so much uh, to say, hey, it's better than this or better than that, but to look at its inferiority to other treatments or interventions, such as COX-2 inhibitors, and we know that there are some negative side effects, health risks that come with using those very powerful pain medications for arthritis. And some of the studies that have come out have been very interesting at looking at how over 3 to 6 months of use, it takes a while. It's not as rapid, in terms of reducing that. So when we look at a maintenance strategy or plan for someone, again, it's something that I think it's out there. We see it everywhere. I'm not here to say one is better than the other, but I looked at the published evidence to give some guidance. And ASU is a compound, avocado soy unsaponifiable, is kind of like allulose, where it's not metabolized and broken down, um, in the gut. And that concentration of avocado and soy, has been shown in some NIH trials to reduce some of the biomarkers for inflammation. So the idea that you could take a more manageable size capsule, because that's sort of knocking down some of the inflammation. Um, again, there's some concurrent validity, I think, in those trials. More study always needs to be done, but again, it's interesting. Um,
Agreed.
it's one of those things where it's a low risk. The biggest risk is to your wallet. Is that $35? Does it help you and benefit you to the point where you want to continue it? Is a lot different than taking something that could be causing either further damage or complications to your cardiovascular GI system.
I agree with you. I've noticed and I've read that the literature on glucosamine is truly stellar. It's been tested and tried in knee injuries, also in spinal disc injuries. I like the combination of glucosamine. It was glucosamine HCl with chondroitin sulfate, adding ASU. So I think that trifecta, is excellent. It's like the three horsemen in Notre Dame 100 years ago. You need all three. You could also add a little omega-3, vitamin D3 with K2, believe it or not, melatonin, and an appropriate pre and probiotic. And now you have a full composite formula for joint health. But I noticed you also spoke about the idea of getting sugars down, reducing inflammation, increasing blood flow, which will ultimately lead to your desired outcome, which is tissue health or cellular regeneration.
And
Could you
movement.
expand upon that a little bit?
Yeah, I mean, why do people not exercise? They don't want to
Lazy?
exercise because they're overweight and heavy, their joints hurt, and they get out of breath, tired. I mean, I think that trying to help facilitate some of the building blocks for positive health behaviors is an interesting intersection. A lot of the people that I see are at, at a variety of different levels in life, whether it's the aging executive or athlete, or someone that's coming up. I mean, we have some outstanding, amazing colleagues here at Hopkins that, I like dealing with the active aging, the person that's a bit more like me. I can relate to them and some of the challenges that they face. I'm not throwing a 95-mile-an-hour fastball.
Neither am I.
So, I think that just like with anything, just like a multimodal approach, I think, a multi-talented approach is important when someone is sort of assigning their, personal board of directors to their health and wellness. I don't think any single practitioner has all of the answers
Right.
in their pocket, but I think that a lot of different people can shape and bring different perspective that ultimately puts the individual at the center of that patient care model. So their physician, their chiropractor, their physical therapist, their massage person, their exercise person, people, it's more and more commonplace today. More kids have trainers today
Right.
than I think existed in professional sports 20 or 30 years ago. So,
Mhm.
I think it's an interesting time in healthcare.
I agree. I think we're at the precipice of some tremendous breakthroughs. What do you see on the horizon in
I,
rehab?
I think what we're really trying to do is find ways to sort of decentralize care. We want to get people to move from hospital to home.
Mhm.
How do we minimize your time in the clinic? And that can be in a lot of different ways, whether it be through what's now called either on the physician side, there's remote physiologic monitoring where they're able to monitor blood pressures and body weights and a variety of different measures there. And in the therapy side, we see remote therapeutic monitoring. So, digital therapeutics and particularly in VR is really interesting. VR is a low cost, delivery system from a technology standpoint. There's most of the headsets out there are very ubiquitous to development and or for development, and it's accessible. So can I extend the time in between your visits or your care by having you working on a digital health platform um, using AI and machine-based learning
Mm.
to help guide you through your exercise program at home. Therefore, when you're coming into a clinic, we can focus our time on the modalities, on the technology, on the specialized skills or treatments that we can do here as opposed to me just standing over and being your monitor. Um, so things like blood flow restriction training,
Right.
while there's some really cool, sophisticated technologies that can be done in the clinic, there's equally interesting home delivery systems, through devices like Be Strong, using bands that are very safe and easy to apply at home is a lot. The paradigm is very similar to dynamometry. Back
Mm.
when I started, everybody used to have an isokinetic. It was a 50, $60,000 device for testing strength. Um, but what do we send them home with? Rubber bands. You know, we have the devices in the clinic that can measure blood pressure and limb occlusion pressure and things like that. But, you know, using it once a week for 15 to 30 minutes is probably not going to be the difference maker for your recovery or rehab. Finding the tools, the self-management tools that we can equip people with. We see it every time you go to Target, you go to Best Buy. They have a whole wellness section now.
Right.
You'll see the percussive guns from Therabody and Hyper Ice. You'll see the sequential compression pumps, the recovery pumps for the lower extremities from Normatec and Therabody.
Love it.
So yeah, there's a lot out there. I think I wandered from your question.
I have a good friend of mine overseas, and he always watches my podcast. And, it really motivates me to try and do a good job. But he always says, when I leave the podcast, I want something digestible that I can do for my daily routine. So give me three things he could do at home to help him with lower back pain, i.e., lower back performance.
Oof. Um, I think first of all, a lot of people stay hydrated. Tissue, in order to slide, glide, move properly, I think when we think about the muscles in the back and where we develop our tension, muscles like a washcloth. It's got fibers that slide and glide on one another. If I'm constantly under tension, I'm wringing out that washcloth. I'm taking that structure and squeezing all of the lubrication out. I'm making it more difficult for nutrients to come in. Um,
Yep.
and so I think that from a
Great, great
self-management
example.
standpoint, some of the very basics, hydrate. I love foam rolling. Foam rolling is like one of the easiest ways to tenderize a muscle.
Mhm.
And in a runner's world study a few years ago, one of the successful habits of the injury-free runner was runners that foam rolled routinely. So however you get that sort of mechanical recovery stress to the tissue, whether it be through a foam roll or through a percussive gun, I think is good. Um, and posture. I think being aware of, the the positions that we find ourselves in, you know, do we change position frequently enough? I know I struggle with that sometimes when I got my desk days. Um, it's hard to get up and move around. So, I look at things like, again, original strength, the sort of the 10-minute movement vitamin. It's hard to talk you through that in a podcast, but I would encourage you to look up the Pressing Reset by Tim Anderson. We've created a little booklet for our patients that we give out, and it has been an invaluable tool for us in helping just get people thinking about that 10-minute movement vitamin.
So to recap, hydration, great idea. Water, electrolytes, etc. Getting those muscle more supple, whether it be foam roller, Theragun, something you can use at home. And lastly, good quality posture, probably based on the posture, based on a neural reset and core activation. So now he's got his three things. So he'll feel imbued with enthusiasm to partake in a home exercise program. Lastly, before I let you go, because I know you're busy, what's next for you personally?
Oof, what's next for me personally? I'm about to take my son on a road trip, so that's for me personally.
That's great.
Taking my son and my mom, so getting some family time to drive up into New England, and make my way from New York to Boston. So
Well,
I'm looking
when you're
forward
in
to
New
that.
York, when you're in New York, you know the guy to come and visit.
I will definitely. I'm actually going to be in New York speaking at the end of the month, so I would love to connect with you at the end of August.
Well, we got to do it without question. I'm 30 minutes outside the city, as everybody knows. I am a New York City guy through and through. I apologize for that. I'm thankful for that. All the above, without question. This was very interesting. There were some really good in-depth answers. Love to have you come back again. Anybody who needs to know, in our show notes, he's got his bio, he's got his contact. We got Ken Johnson from Johns Hopkins, the most humble, erudite I know.
Thanks so much, Dr. Rob. I really appreciate the privilege of being here today.
My
Thank you.
pleasure. It was all my pleasure.